Hi, I'm Steve Stahl, and I'd like to talk to you a little bit about our new book with Jonathan Meyer and myself on using plasma antipsychotic levels to guide dosing. What? Nobody thinks that plasma antipsychotic levels mean anything, right? That's the common idea. And we actually would agree that for the average patient and for routine use, you don't not need plasma antipsychotic levels. But what happens if your patient isn't responding to an antipsychotic? And I would say it's like trying to drive at night. You're out there, it's dark, you don't know where you're going. And so, what do you do at night if you're trying to drive? Turn on your headlights. So, we think that clozapine and olanzapine and many of the haloperidol, dozen of antipsychotic agents, you turn your headlights on by getting their level. And it will tell you a number of things. We have such experience at the Department of State Hospital in California, where there's 7,000 patients in 5 hospitals, and we've been doing this for 20 years. And although there are not a lot of studies out there other than, if you will, experiential and clinical trials that are really open label, there is a phenomenon in medicine called evidence-based practice. Well, guess what? There's also a phenomenon called practice-based evidence. And so through that practice-based evidence, we've compiled a list of what's the minimum therapeutic level in your blood that you have to attain to have really any chance of the drug working. And a new idea. Are you ready for this? The point of futility. What the heck is that, Dr. Stahl? Well, we say that your dose of your antipsychotic agent should not be dictated merely by the dose range that's in the package insert by the drug company. Now, that's where you start. That's where the clinical trials were done. But remember that the clinical trials were done in patients who were not treatment resistant, much easier than the kinds of patients that we're talking about. The patients we're talking about wouldn't have gotten into those trials because they were too sick. So, what do you do for them? And the answer is you get a plasma antipsychotic level when they're not responding. If it's not even above the threshold, well, easy, you just increase the dose. No matter what the dose is, you have to increase it. But also, if it's at the top dose, you don't get credit for the number of pills you take. You get credit for the number of molecules you get into the brain. And different people need different amounts of molecules in their brain. And you can increase the dose while monitoring the plasma drug level until you reach the point of futility, or you reach it works and then you stop at that dosage level, or you reach a side effect and you have to stop or lower the dose. What is the point of futility? It turns out there are many people you can raise the dose and not have side effects, and then you get a very high dose, you still don't have side effects, it's still not working. Well, there's a point at which you should stop, because fewer than 5% of people will respond if you go above that dose level in your blood, the plasma drug level. So we have put in the book not only threshold doses for a minimal onset of the drug working, but also points of futility, that even if you tolerate it, don't go any higher than that, because it might even be safe, but it's just dumb because it isn't going to work. So we have articulated that for over a dozen drugs, the ones that are most commonly used, and hopefully this will be a good guidance for that. This is a good sort of a reference source for those of you who want to know where this is documented. We have the literature. We've written some of that literature ourselves in the journals, but also we've reviewed the world's literature and given tables of evidence. So hopefully that'll be useful. Well, one of the new emerging technologies about plasma drug levels is one specifically for clozapine at the point of service. Now, one of the problems is that people don't like their blood being drawn, particularly patients that are taking clozapine, because they have to have their blood counts monitored. So the last thing you want is another blood draw. So there's this finger stick technology. and the machine is right there at the bedside. So you can literally just do a finger stick like for diabetes, so get 1 drop of blood, take it on over to the machine, bang, you know your clozapine level. Now, that technology is very useful and will facilitate the use of clozapine in any setting. Outpatient, patients just come in to get their clozapine levels looked at, so you can guide dosing. We don't have that for the other drugs. In theory, it could be done, and I think there are companies working on that technology. But right now, the point of service technology for finger sticks, blood levels of an antipsychotic is confined to clozapine. I think this book will be most useful for clinicians treating patients who fail to respond to 2 or 3 known antipsychotics at their usual dose range. At that point, what do? Quit or do nothing? No, the answer is get a blood level. And this will tell you whether the patient is one of 2 types. Either they're a pharmacokinetic failure or a pharmacodynamic failure. A pharmacokinetic failure means the blood level never got high enough, even for a normal person. And so you don't know that unless you look. And the usual cause of pharmacokinetic failure, of course, is noncompliance. But there are some people who take their drug and still don't have enough in their blood. And the point of that is if they're non-compliant, you can use a long-acting injectable, which basically, you know the patient's gotten it because it's in their system, or you do other kinds of interventions. If it's a pharmacodynamic failure, that means that despite having what is normal amount of drug for persons in the clinical trials of easy cases, your case is not responding to that. And so then you say, what do I do? And the answer is get a blood level. And if it's in the usual therapeutic range, but it's not yet to the point of futility, you stepwise increase the dose, get another level until you get up and the patient either can't tolerate it or responds, or it reaches a point of futility where you might as well quit. It turns out you will be surprised at how often going from the normal dose of a drug to the point of futility, in that gap, you will find a lot of responses to treatment-resistant psychosis. Not everybody, but a lot. So the issue is that when you have a treatment-resistant psychotic patient that isn't responding to a few different antipsychotics in the normal dose range, get a level, raise the dose, go to the point of futility, and I will guarantee you that you'll get often a good response if you do that. That's why you do the levels.